Hi, and welcome to another lecture on pharmacology for infectious diseases. For this lecture, we'll be focusing on anti-protozoal drugs. I divided this lecture into two parts. The first part will deal with amoebiasis and leishmaniasis. For the second part, we'll deal with trypanosomiasis, Chagas disease, and other protozoal diseases. For the learning outcomes, you have to be able to enumerate the commonly used drugs for them, determine the drugs of choice for these diseases, and discuss the mode of action and notable pharmacokinetics and adverse reactions of these medications. These are the things that we'll talk about. So, for the first disease that we'll talk about, this is amoebiasis. So, we know that amoebiasis is caused by an entamoeba histolytica. The infective stage is yung cyst. It's an intestinal disease, but it can also be an extra-intestinal disease. So you have to know your patient from history and from PE whether they are having an intestinal disease or extra-intestinal disease. Okay? Because the drugs of choice for the two types of diseases would be different. So, for intestinal diseases, you will need a luminal amoebicide. So, it's an amoebicide that will be present in the lumen of the intestines. And for the latter, you need a tissue amoebicide. So, when we say extraintestinal disease, they can be found in the liver, lungs, or brain. The picture on the right just shows you the life cycle of your entamoeba histolytica if you want to review. So, for the amoebicides, you will need to know again if it's intestinal or extraintestinal. For asymptomatic intestinal infection, including cyst carriers, you will need a luminal agent. For this, the drug of choice is diloxanide furoate. In the US, it's paramomycin. Alright, so you have DIP, DIP. Another is that's iodoquinol. It's like iodine based, okay? Iodoquinol. Then, for other types of infection, mild to moderate intestinal infection, you will need metronidazole. Severe intestinal infection, you will need metronidazole as well, together with the luminal agent. Hepatic abscess and other extraintestinal disease, you will need luminal agents as well, plus metronidazole. Okay, there are also alternative drugs. As you can see there are certain antibiotics like tetracycline and erythromycin that can be used against amoebas. Okay, here in the Philippines, actually, it's very common if people are experiencing mild to moderate intestinal infection to give just metronidazole. Okay, but according to Katsung, the best combination is to give metronidazole plus a luminal agent. Okay, so for luminal amoebicides, they're further subdivided into non-antibiotics and antibiotics. They are also used singly for the treatment of asymptomatic amoebiasis. They kill the free-floating trophozoites, not those lodged in the tissues. So you'd expect that these drugs will most likely remain in the lumen in order for them to be able to kill the trophozoites there. So for the non-antibiotics, you have diloxanide furoate and iodoquinol. For the antibiotics, we have paramomycin, tetracyclines, and erythromycin. For the drugs of choice, you have DIP. For you to be able to remember this, if wala kang symptoms, if you don't have any symptoms, take a DIP. So this is for asymptomatic carriers. DIP, DIP, again, are those three. So let's discuss each drug one by one. Diloxanide furoate, the MOA is unknown, and that's the indication. We already talked about that. It's a drug of choice. It's not effective for extraintestinal amoebiasis. Okay? Pharmacokinetics, well absorbed, well tolerated. but 10% of it is actually not absorbed. Okay? So yung unabsorbed part, the 10%, is actually what you want, what you need in order to kill the amoeba in the gut. The 90%, they are absorbed and conjugated into glucuronide, so they won't do anything, and then they will be excreted in the urine. I said reverse of iodoquinol because in iodoquinol, 10% is absorbed, 90% remains in the gut. Okay, so adverse effects, local GI effects include vomiting, pruritus, urticaria, the common ones. This is the dose. Don't memorize the dose. Okay. The next one is iodoquinol. They directly kill the protozoa. This drug directly kills protozoa. They are effective against luminal trophozoites and cyst forms, but this is not a DOC. MOA is also unknown, so you don't have to memorize a lot. Pharmacokinetics, like I said in the previous slides, 90% remains in the intestines, and they are the ones that kill. Those drug particles are the ones that kill the trophozoites and cysts. It should be taken with meals to limit GI toxicity, to limit adverse effects like nausea, vomiting. Okay? It can also cause agranulocytosis. So compared to diloxanide furoate, iodoquinol is actually more toxic. It can also cause optic neuritis, optic atrophy, increased protein-bound serum iodine, peripheral neuropathy. So since this is iodine-based, you want to be careful when giving this because patients with thyroid disease, diba, will have abnormal levels of iodine, and those who are sensitive to iodine. So, kunyari, yung mga sensitive to mga povidone iodine, yung mga ganon, don't prescribe this drug. Okay? It's not known to produce these effects in recommended dosages. So, only if they exceed, if they overdose. That's only when they will experience all of these adverse effects, or some of them. Contraindications include also optic neuropathy because it can worsen the disease, severe kidney and liver disease. Discontinue if the patient has persistent diarrhea and signs of iodine toxicity like dermatitis, urticaria, pruritus, and fever. The third drug that we'll be talking about is paramomycin, which is a drug of choice in the USA. Similar efficacy, less toxic, and may be superior to diloxanide in asymptomatic infections. Also used parenterally for visceral leishmaniasis, okay, which we'll talk about later. The MOA, paramomycin is an antibiotic. It's an aminoglycoside that inhibits your 30S subunit. So, paraminoglycoside, for you to remember. Okay, pharmacokinetics, poorly absorbed after oral administration, 100% recoverable in the stool. It's an alternative drug because it's poorly absorbed and it's compensated by taking it for 5 days. Adverse effects, occasional nausea, so GI effects, heartburn, emesis, pruritus, ani. Prolonged use can lead to superinfections, especially Monilla. So it's mainly an antibacterial, that's why it can also kill normal gut flora. So this is the dosage. So just a reminder, unknown MOA for diloxanide furoate and iodoquinol. Paramomycin is a 30S subunit inhibitor. So now we already discussed the 3 luminal agents. Let's now go to the extraintestinal or the tissue amoebicides. If they are not in the lumen, they are found somewhere else. You have to meet them there or met. Okay? Meet. Kasi ME. ME and then E and then T. So you have to meet them inside the tissues. ME for metronidazole, E is emetine, T is tenidazole. Of course, a drug of choice would be metronidazole. It's very available in the market. It can also be cheap if generic. Okay? It's a drug of choice for extraluminal amoebiasis and also used for intestinal amoebiasis. In the Philippines is the one that we use. Actually, in some hospitals they don't give um an intestinal amoebicide anymore. Also, the DOC for anaerobic bacteria and protozoan infections like Giardia and trichomoniasis. The MOA, it is an inhibitor of DNA synthesis. So it destroys the helical structure of the DNA, causing strand breakage and impairment of cellular function. It has the capacity to penetrate the tissues and cause DNA disruption and cellular impairment. Hence, it's used for extraintestinal tissues. Adverse effects can cause strong reactions at normal doses. It has a metallic taste. You can have GI disturbances. More serious ones include peripheral neuropathy, seizures, chest pains, palpitations, transient eosinophilia and leukopenia, rashes, serum sickness-like reactions. So, ideally, it should be used with the luminal amoebicide for mild, moderate, and severe intestinal amoebiasis and for extraintestinal amoebiasis. Tinidazole, letter T, it's almost the same as metronidazole. Uses intestinal and extraintestinal amoebiasis just like metronidazole. It can also be for trichomoniasis, giardiasis, and leishmaniasis. Anaerobic bacteria that can cause septicemia. So it's also good for that. May generic version ng tinidazole, but it can also be combined with other medications like thioconazole. Specifically, tinidazole plus thioconazole can be found in a drug with the brand name Gynamax, and they market it for bacteria for infections of the vagina. Okay? Tinidazole, bacterial vaginosis. Yun. For tinidazole, the MOA is still DNA inhibition just like metronidazole. Advantages over metronidazole, it has less side effects. And administered as a single dose daily for 4 days due to high half-life. Okay? The third one is emetine, which is transformed into dihydroemetine in the body. It's an alkaloid derived from ipecac. And originally, it's used for emesis. Emesis is vomiting, to induce vomiting in toxicology. So for certain toxins that you have to vomit out to prevent further effects, emetine was given before. Okay? It's last resort because there's metronidazole, there's tinidazole naman in the market. So this is just for academic purposes. It's for the treatment of severe intestinal liver amoebiasis. And the MOA, it binds to the 40S ribosomal subunit, decreases ribosome RNA interaction to decrease protozoal protein synthesis. It can also block adrenergic and cholinergic transmission in humans. That's why it has a lot of side effects like the following: cardiotoxicity, arrhythmias, heart failure, and hypotension. So don't give this drug. This is just nice to know. And compared to metronidazole and tinidazole, it's given via subcutaneous injection or intramuscular injection. Okay? In summary, metronidazole and tinidazole, the MOA would be DNA synthesis inhibition. Emetine binds to ribosomal 40S subunit. It's a last resort because it's cardiotoxic. And for the notes, the drug of choice would be metronidazole pa rin. Alright, so for the second infection for this section, we're gonna talk about drugs for leishmaniasis. This is just a picture to review you of the leishmaniasis, which is transmitted by your sandflies. Okay. And the infectious stage is yung promastigote stage. It's endemic in 88 countries. More than 90% cutaneous leishmaniasis found in Iran, Afghanistan, Syria, Saudi Arabia, Brazil, and Peru. 90% of visceral leishmaniasis found in Bangladesh, Brazil, India, and Sudan. So medyo Asian and Brazil. Yung isa medyo Middle East and South America. Okay. So there are actually 4 types of leishmaniasis. This is just a review. I hope that you already discussed this in parasitology. Okay. So visceral leishmaniasis is the most serious form. It's very fatal if left untreated. And it can cause what we call kala-azar. Okay, that's how I remember it. Kala-azar ka, like the disease. Okay. VL. Kala-azar ka kasi hindi mo grinat yung VL ko, vacation leave. So that's a worker saying, that's how I remember it in my mind. Up to you how you want to remember it. Leishmania donovani is the cause. Cutaneous leishmaniasis is the most common form. Okay? It causes 1 to 200 simple self-healing skin lesions. Okay? But it can cause scarring. Example would be Baghdad ulcer, Delhi boil, and others. Caused by L. Leishmania major in Africa and Asia. The third one is the mucocutaneous leishmaniasis due to Leishmania brasiliensis and begins with skin ulcers that spread and cause mass tissue destruction, most especially in the nose and the mouth, kaya siya mucocutaneous, pati mucous membranes. Diffuse cutaneous leishmaniasis produces disseminated and chronic skin lesions resembling those of lepromatous leprosy, and that's difficult to treat. So, order of the drugs, the major drug is sodium stibogluconate. First alternative is pentamidine, given in the early stages. And second alternative is miltefosine. So, SPM. Spam. Okay. The first drug is sodium stibogluconate. It's a DOC for leishmaniasis, but remember, it's also very toxic. It has a lot of adverse effects. It's as harsh as its disease. Okay? The MOA, it's a tetravalent antimony. Yun yung, di ba yung element? And unclear yung MOA niya, but it might inhibit ATP synthesis. So, kaya siya STIBO, di ba? ST. The chemical symbol. Ay, SB pala. SB, sorry. Pharmacokinetics, it's given IV. Metabolism is in the liver, excretion is in the urine. So this is the dose. And adverse effects, it may be life-threatening. So you have to check. You have to weigh the risks and benefits of giving this drug. Okay? Because antimony is toxic. Intolerance, if the patients can't handle it, they can experience shivers, fever, arthralgias, myalgia, skin rashes, and abdominal symptoms. And it has a lot of toxicities like myelosuppression, cardiac effects, sudden death in excessive doses, and pancreatitis. So you make sure that the patients don't have pre-existing conditions when you give this. Okay? Especially cardiac, liver problems, blood dyscrasias. And of course, it's gonna be contraindicated in pregnancy. Pentamidine is the second drug. It's an alternative to sodium stibogluconate. MOA is also unknown, but it can inhibit synthesis or replication of DNA, RNA, protein, and phospholipid. So they don't really know, para ma-make sure lahat na lang. Okay? May inhibit synthesis, almost 5, no? But it's just 4. Penta. DNA, RNA, protein, phospholipid. Maybe synthesis will be the 5th word. Okay? So that's how you remember it. Penta, 5 words related to its MOA. Binds to and aggregates ribosomes, therefore resulting in a decrease in protein synthesis. Uses, it's also used for pneumocystis pneumonia and pneumocystis caused by pneumocystis jirovecii, which is one of the most common causes of pneumonia in HIV/AIDS patients, mga immunocompromised. So a lot of AIDS patients actually die from pneumocystis pneumonia. It's also used for African sleeping sickness, second to Suramin. And second Line for visceral leishmaniasis, second to stibogluconate. So it's also for Pseudomonas infection and used for other protozoal infections. It's poorly absorbed. That's why parenteral yung route. It can also be given as a nasal spray or nebulization. And metabolism is via the liver. This is the dosage suggestion. Adverse effects. So, may kinalaman din siya sa pancreatitis din, and diabetes mellitus because they're toxic to the pancreatic beta cells. Blood dyscrasias and hepatotoxicity, just like stibogluconate. Bronchospasms, which is kind of unique here. Leukopenia, thrombocytopenia, and severe hypotension. Major, more immediate effects if via the IV route, so you have to be careful talaga. And hypotension, tachycardia, syncope, or urticaria, yung mga common ones. Plus, heart effects, dysrhythmia, okay? The third one is miltefosine. It's an acetylcholine analog, and it's also used as an oral anti-neoplastic agent. So it's used for cancer. So it alters replication and affects cell signaling and membrane synthesis. So it's well absorbed in mice, no human data yet. The metabolism is in the liver, excretion is via the urine. Okay? Unknown pregnancy status, because not many studies have been done for this. Major would be retinal degradation, hepatitis, and renal failure. So all of them, you have to be cautious when treating leishmaniasis in general, especially for patients who are already suffering from kidney and liver disease and blood problems. Okay, how do you know? How do you remember? SPM, sodium gluconate, stibogluconate, pentamidine P, and M is miltefosine. Isipin nyo yung picture na to, spam leishmania flavor. Yuck. So all of these drugs are very toxic. Alright, so that ends my first part. You can have a rest before you begin with the second part. So just a review. We have 3 mnemonics: dip, meat, and spam. Spam leishmania flavor, meat for extraintestinal